Today I'll discuss on management of portal hypertension. So portal hypertension means portal venous pressure when it is more than 10 to 12 millimeter of mercury. Then it is called portal hypertension. Number one measurement, that is resuscitation. You immediately start open an IV line with the IV fluids, then transfuse packed cells, fresh frozen plasma, platelet infusion as indicated, as indication comes. Looking at the reports, based on the reports, you start with all these transfusions. But always try to avoid over transfusion because it may result in overfilling of the intravascular space and increase the portal pressure further. So just carefully you need to do the transfusion of these things. Then go with the measures to stop bleeding. Give vitamin K to correct the coagulopathy. Then put a NG tube in situ so that and lead to continuous aspiration so that you can assess of the ongoing bleeding. Then start H2 receptor antagonist, either ranitidine or cimetidine or PPI, proton pump inhibitor, you can use to reduce the risk of bleeding from gastric erosions. Always give IV antibiotics because during the varicose bleed they are at high risk of infections. You have to use arteriolar vasodilator. So usually used are nitroglycerin. And another drug is somatostatin analog or octreotide. This is a better choice or should be the first option, as this has minimal systemic vasoconstriction effect compared to vasopressin, so this is more safe. So initial drug of choice for the acute varicose bleeding should be octreotide. So many times this is not available and it is expensive, so for that reason many places they use vasopressin. If still bleeding, then you go with the endoscopic sclerotherapy, or you can use Blackmore Sanger-Steken tube, or go with the TIPS or Shigora operation, and then finally liver transplantation if it is a hepatic cause of portal hypertension. So definitive treatment is done by endoscopic therapy. This is the most effective non-surgical therapy. So here endoscopic varicose sclerotherapy and varicose band ligation is done, and this is an initial intervention of choice, and the success rate is quite good. It is 80 to 100%. Just a picture showing the band ligation. Other options are mechanical therapy, Sanger-Steken Blackmore tube. So these days this is usually not used. It is alternative therapy for patients who are failing the pharmacological or endoscopic therapy. In this there are two balloons. So inflatable balloons are there which directly compress the varices. It has two balloons, one for esophageal, and another is a small gastric balloon, which compresses the varices and then stops the bleeding in 70 to 80% cases. It is rarely used nowadays, but it can be an option to control the life-threatening hemorrhage when immediately you cannot go for endoscopy, or if endoscopic therapy is not available, then you can go with this option. Now come to surgical procedure, which is required in many conditions if all the medical measures fail. The emergency surgery is indicated. So in the emergency you can do shunt operation, where you can totally diverting shunt, you can do end site portocable shunt, partially diverting shunt you can do, that is side to side portocable shunt, and selective you can do, that is distal splenorenal shunt. The indication for surgeries are recurrent varicose bleed, if the child develops hypersplenism, or if the cause is intrahepatic disease, then usually surgery is required. So in case of children, extrahepatic causes are more common. So many times just the endoscopy is sufficient for these children. They don't have to go for intrahepatic disease. Intrahepatic causes are less, so maybe surgery is not required in them. The surgical procedures, you do devascularization or transection of the esophagus, which blocks blood flow to the varices. You can do transjugular intrahepatic portal systemic shunt, also known as TIPS operation. So here temporary shunt is placed between the right hepatic vein and right or left branch of the portal vein via a catheter to decompress the portal pressure. Success rate is 90 to 100%, so this is a good option. This is the first line treatment for bleeding esophageal varices. So if the cause is hepatic cause, you can go for liver transplantation. That is the only definitive procedure if the child is having cirrhosis. And in case of portal hypertension, you need to give prophylaxis treatment. So medical or pharmacological prophylaxis is given by beta blocker. We use usually propranolol at dose 1 to 2 milligram per kg per day to lower the portal pressure. And then another option is obliterative endoscopic sclerotherapy. This sclerotherapy is done every 4 weeks until all the vein in the low esophagus is obliterated. You give injection in the varices with the sclerosant. And management of associated problems. If there is a hypersplenism, you can go for splenectomy. If cirrhosis with hepatic failure, then liver transplantation. So that way associated problems can be managed. And prognosis in the intrahepatic disease, prognosis is poor. Progressive liver disease, hepatopulmonary syndrome or severe veno-occlusive diseases, they require liver transplantation. And if there is a triad of jaundice, ascites, encephalopathy, 80% is the mortality, so has a bad prognosis. Thank you.